Hello and welcome back to the Healthcare Executive Insights podcast. My name is Elliot Sloan with the Macallan Group. Today we're super excited to introduce our guest, Mr. Andrew Lovewell, the CEO at Columbia Orthopaedic Group. Andrew, thank you for taking time to chat with us today.
Thanks for having me, Elliot. I really appreciate it. I'm looking forward to our conversation.
Likewise. So let's start with an introduction and tell us a little bit about your professional background, and then we'll move into more information about Columbia Orthopaedic Group.
Yeah, sounds great. So as you said, my name's Andrew Lovewell. I'm the CEO of Columbia Orthopaedic Group. We are a private practice musculoskeletal and orthopedic group here in the mid-Missouri area, kind of smack dab in the middle of the state. Our group's been around since 1965. We've got 26, 27 physicians that kind of specialize in musculoskeletal and orthopedic care, both non-operatively and surgically. Prior to this role, I worked for the group and ran our outpatient surgery center. We have a 32,000 square foot ASC that's got 6 ORs, 12 pre-op, 12 PACU bays. We do about 6,400 surgeries a year in our surgery center. Roughly about 75% of our volume is done outpatient today compared to, what it was, years ago. Part of that role, I was in Illinois for a couple of years with a big surgical group there. We covered, a significant amount of real estate all the way from dang near up to Chicago, all the way to Southern Illinois.
Wow.
50 plus locations, 12 hospitals,
Wow.
75 surgeons. And then I worked for a large academic medical center before that in various roles: finance, accounting, privacy, compliance, pharmacy, kind of all over the health system, just working on different projects.
Well, you certainly must have a knack for fixing problems and addressing hard challenges.
Yeah, that's a huge passion of mine. It's just breaking something down and working through it and figuring it out one step at a time. The best way to do that, from what I've found, is just, get a good team put together, work through it as a group, group think it, work, deconstruct every little thing, get to the source, solve it, and then move on to the next problem, because, healthcare is just littered with problems all over the place. So.
Yeah, it certainly is. And it seems like we're kind of at a breaking point where we got to turn the ship around before it gets even uglier.
Yeah, there's like that critical mass point that happens, kind of using that ship analogy, right? It's pretty hard to turn an aircraft carrier around. Pretty easy to turn a speedboat around. So, healthcare, just imagine it being the largest aircraft carrier in the world out there in the ocean. And we're trying to manipulate this thing and say, let's figure out how we pivot in a system that's not meant to pivot. Mm-hmm. And how do we get this done? So, yeah, I mean, we're at that point, it's kind of the break fix mentality that healthcare has put on itself for years over, it's a broken system, let's fix it. It's a broken system, let's fix it. We haven't got there. We haven't fixed it. We haven't done anything yet to really drive value or improve things. I don't know what the course of the next 5 to 10 years looks like for our healthcare system or private practice or anything, but just take it one day at a time, right?
That's all you can do, and get the stakeholders to all come to the table and figure out where do we start, because it's so complex. And the patients are the ones who are suffering at the end of the day. Yeah. What do you think are our most pressing issues for private practice in the landscape we're in today and heading into 2024?
Yeah, I think that's a great question. For us in the private practice world, we're dealing with what everyone else is dealing with. There's the significant margin compression. There's a projected Medicare physician pay cut again coming up. I don't know how in the world that could happen when inflation's 8-9%, but we're going to see another downward trend in, physician reimbursement. And then in all reality, it kind of just comes down to solvency. You look at the market today, the statistics kind of show roughly 3/4 of all physicians are employed by some sort of system. Now, whether that's an academic system, a hospital, a private equity group, there's various different employment models that exist for physicians. So the world of private practice is very much just like, it's not the norm. It used to be the norm, right? Like everyone got out, they hung their shingle, they went out to work, they rolled their sleeves up, and they took care of people. And there's still docs that are doing that, but it's not in the numbers that it was before.
Sure.
When I think about the private practice world over the course of the next 3, 5, 10 years, it's really going to come down to how well can groups mold and come together that are private today. How well can those groups come together and say, you know what, I'm private, you're private, we think very similarly. Let's merge, let's do a divisional model, let's do something to where we can get some momentum behind us, get some economies of scale, get some economies of value, to our patients, because that's really what it comes down to.
Sure.
And then is there to drive any type of negotiation with the payers to say, we're now, we stack all of our revenue together. We're not a small fish anymore. Now we're a medium-sized fish. I don't think you're ever going to be a whale in our market with private practice, because it's almost impossible with how many docs are shifting to go into the employed model. So
only few Optums out there.
Yeah, I mean, what is it? What's the statistic? Like Optum employs more physicians in the world than anybody else.
Wow.
I mean, you think about that and you go, holy crap, how's that even competitive? They employ what, 40,000 plus doctors at this point. So there's definitely like significant challenges that exist, but there's significant opportunity, right? There's a niche. If you're a private practice group who's nimble and does a good job and can transition and do things for patients that they're not going to find in a big system or a big Goliath system like that,
Yeah.
you're going to do just fine.
Yep. Yeah, it seems like the big health systems have the resources but lose the personal touch, and it kind of creates a non-competitive environment for these docs to push themselves to be able to deliver the latest and greatest healthcare to their patients.
Yeah, 100%. It's like you look at all of the things that you try to do from a value creation or value delivery perspective for patients today. A lot of those things aren't necessarily tied to increased reimbursement, increased profit margin for your facility. It's just increased value delivery to the patient, so they choose you over somebody else in the private practice world. So I think that's kind of a little bit of a lopsided equation, where if you look at the groups that are out there that are striving to do well for their patients, they're doing it because, one, it's like a defensive mechanism, right? To say, hey, we now provide ABC.
Yep.
Well, it's not going to cost any more money. It's going to provide more convenience, which provides more value for the patient. But that's really where we're headed, is like you're going to see more groups, private groups like ours, private groups like a lot of other ortho practices like us. You're going to see more of them look to create value through delivering different solutions. That could be tech, it could be experience, it could be, they put in a lab at their main office for convenience for patients. That there's going to be a plethora of different things that groups try to just, make sure that they're capitalizing on a captive audience, right? Like they're making sure their patients have what they need. So I think that's going to end up being the differentiator.
For sure. It's, these groups really not only to provide better experience for patients to survive with their reimbursements getting cut, they have to find other ancillary services and revenue sources to keep status quo and keep the lights on. And we're seeing it a lot, with clients we work with through our agency. You got groups bringing in psych and mental health that, realize a lot of their pain patients also have mental health issues. And while they're here, why don't we get them that treatment that they need? So I think we're heading in a direction that single specialty practices will find it very hard to survive. What are your thoughts on that?
No, I agree. I think that's where, like I said, we're a multi-specialty musculoskeletal group, right? Like we're
Yeah,
subspecialized orthopedic physicians in our group. But if you look at us from the outside, kind of looking in, it's still single specialty. So, for us, we're looking at that same kind of approach. Is there an integrated delivery model that we can come up with where we bring in rheumatology or we bring in radiology, anesthesia, all of these kind of multimodal touches that continue to say, okay, we're not just this, we're this plus 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 plus. And I think it's very apparent, in our marketplace at least, we got a big university system that we compete with. And the way we compete is really not in cost because they're just so much more expensive. It's in access, it's
yeah,
in physician shortages. Like, rheumatology in our market, there's no private docs.
got it.
you know Urology, there's like 3 private docs in our market. So like it kind of comes down to like there isn't a choice at some
Sure,
point for patients, and not having choice is bad. Like
sure,
that's not, patients need to have an option. So I mean, you're spot on with that. Like you're going to find, I think, where a lot of big groups, they come out and they say, you know what, let's all do this together. Let's solve this together. Let's say, you know what, the sum of all of us combined is what's going to be the answer, not small parts. So let's figure it out. Let's come together. We can figure out all of the control and the overhead and all these different things down the road. But really, what it comes down to is we got to take care of our patients.
sure,
And the bigger you are, the better you are. Because the bigger you are, if you're a self-funded insurance plan for your own employees, you're going to be able to provide better insurance coverage. You're
sure.
going to be able to provide better solutions to your own group, other groups. Like there's just significant opportunity when those groups kind of pull down the
Yeah.
walls, take the ego, put it to the side, and say, okay, let's just roll up our sleeves. How do we do this?
Strength with numbers. And
100%.
also with those numbers, you get better negotiation power for contracts with payers, which means you can recruit better talent to join the team. And
Yeah.
ultimately, that delivers better care.
Yeah. I mean, there's some of these groups that are out there. You look at like the 2 or 3 man groups that exist. There's like a private group that I'm aware of where there's 2 docs in the group, right? And they're trying to bring in a third person. And I'm like, well, who the heck wants to be on call every 3 nights? Like, no one wants to sign up for that.
Sure.
Or how the heck do you even recruit somebody? If there's 2 of you, at some point in time, one of you or both of you take a pay cut to hire a recruiter to bring somebody in, and you don't have the time. As a doc, you're so overburdened with everything else you're working on. You're doing predeterminations, prior authorizations, you're running a business, if you're a private group, you're trying to employ people, you're doing all of your own like bookkeeping or
Yeah.
accounting. Like we got a group we're getting ready to actually acquire in our market. The doc's like, man, I was up at 2 a.m. doing my payroll. And I'm like, that sounds terrible. And he's like,
Yeah.
yeah, why do you get out of this? Like, I don't want to do this anymore. Like
Sure.
I want just want to, and this is the easy button, right? I just want to work and I want a job.
Yeah.
I'm like,
That's a quick route to getting burnt out. Payroll at 2 a.m.
yeah, 100%. Like I ain't up at 2 a.m. doing our payroll. We've got an HR person, who's like doing
Sure.
that during the day. Like you can't be in a position where like you're overburdening yourself with all of this administrative stuff because the only way you're gonna continue to get patients, continue to get paid, and actually continue to be in business is by seeing patients. Like that's the only way it's gonna happen. You've got to be in the trenches, doing the work, taking care of patients, and opening the funnel. Like you can't be in a boardroom, you can't be having meetings, you just can't be in that position anymore. Medicine's
Sure.
just changed so much where the entrepreneurial physician, there's so many things on their plate that the hurdles to get over to run a private group on your own are so severe that most docs, like I said, the statistics, 75% of them are employed. Most docs just throw their hands up and they're like, nope, I can't do this.
Yeah. And they went to medical school. They didn't go to business school, right? They're trying to learn as they go. And it's how do you give your patients the best care if you're also trying to grow a business?
Yeah. Well, and I think like the doctors are really smart people,
Very smart.
very, very smart people. And they got through medical school, and especially those that are subspecialized through residency and fellowship, highly intelligent individuals.
No
But
doubt.
many of from the business side, there's some of them who just don't like it. They don't
Yeah.
want to do that. They
Yeah.
just want to provide patient care. And there's
Yeah.
some of them, our president of our group, he's got an MBA. He went back to school, got an MBA, invested in his own financial acumen because he's like, I want to know how to read these financials. Like,
Sure.
I want to know how to read it on my own. Yeah, you can tell me, but I want to know how to read it on my own as well.
Sure.
And like, our vice president's going to do the same thing at some point. He's like, I'm a young leader. I want to figure out this stuff too. Like, this is important if you're going to be in a business like this. And that's great that they have the opportunity to do that. A lot
Sure.
of these docs that are in practice, like there's some docs, who still kind of do the old school internal medicine thing where they round on patients, see patients in the morning. They're working until 6 o'clock at night. They go round on patients again, and then they're home for 4 or 5 hours. I don't know how you live like that, right? Like,
It's
how would
crazy.
they ever MBA and figure out how to run their practice efficiently? They don't have the time.
Yeah. I mean, no doubt doctors are lifelong learners and they're always pushing themselves to evolve and learn more. But there's just not enough days in a lifetime to be a phenomenal doctor and a phenomenal CEO of a large group.
Yeah, that's like I think our previous president used to tell the story. He read an article. Now it's back like in the late '80s. Um, the doctors were writing into Jack Nicklaus, the golfer,
Yeah.
Jack Nicklaus. Sorry, and they wrote in and said, "How could I be a better golfer?" And he goes, "Quit being a doctor. Like, there's no way you play golf 5 days a week
Yeah.
and do doctor things 5 days a week. Like,
Sure.
you just don't have time in the day. So that's really what it comes down to. It's just repetition. And like you said, physicians are continuing to master their craft all the time, do CEU, CMEs, go to conferences, all those different things just to
Yeah.
get better.
Yeah.
But at what return is the question, right? Like, if I'm going to continue to invest in my own, skill set and treating my patients, and my reimbursement goes down year over year over year over year forever through my
Sure.
entire career, um, what
Sad.
what am I getting out of it?
Yeah.
Like we've got a couple docs in our group who have been in practice 30 plus years, and he's like, the quickest way to get a pay cut, become a doctor.
Yeah.
I'm like,
It's crazy. We're seeing it happen in the Northeast a lot, where a lot of these out of network specialists, neurologists, orthopedic spine, these guys that are the top of the, I'd say ladder as far as their education and training and difficulty to be a great in those specialties. So you would expect those guys to have, different out of network reimbursement contracts with all these payers, which a lot of them, were out of network for many years and, would find or would be able to treat a lot of patients that have some of these better insurance plans. A lot of the municipality workers would have great insurance, the teachers, the police officers, firefighters. And now all of those plans have really evaporated and nobody has these out of network benefits anymore. And so the doctors are like, what do I do? I guess I have to go in network. So they go to Horizon and say, I want to have a conversation about coming in network and renegotiating my contract. And our clients are telling us, they're saying, sorry, it's not open. We're not taking
yeah,
new providers in our in network policies. So at that point, they have no option but to go work for a health system or go work for another practice that might have these contracts in place already. But these were previously the most premier positions you can hold in the private practice space, and now they have no options. It feels like.
yeah. Yeah, it's like, I was at the Becker's conference in June in Chicago, and one of the docs there, guy in California, he's talking about his surgery center, and he goes, I got to a place where I was taking care of some of these United Healthcare employees, and then SCA launched a Center of Excellence program and said, "You're no longer inside of our program anymore. You're no longer participating with United Healthcare. You're done. You're off our insurance plan. You can't see these patients because you're not a Center of Excellence." And he's like, "Well, how do I become a Center of Excellence?" And they kind of laughingly are like, "Well, you're not an SCA center,
Yeah.
which is owned by also, right?" So like they're getting both sides of the coin here. They're like, we've got, I just looked the statistic up. It's 70,000 employed doctors. I thought it was 40,000. That's even scarier.
Wow.
Um, so they got 70,000 employed doctors. They got the SCA management arm of this, and then they got the insurance arm of it. And it's like game, set, match. We've got
Yeah.
every element kind of lined up. And if you're not if you're not an SCA doctor and you don't see our patients, you're just not going to be in network. That's just the end of the discussion.
That's wild.
So like, it's absolutely crazy. And like, we haven't had that, dramatic of an impact in our market just because there's really no, outside of the university, there's no competition.
Yeah.
But even at that, even if there was competition, like I wouldn't look for any of the payers in the Midwest to really practice the same way they do on the coast. Midwest has really kind of been isolated from some of these, crazy payer schemes like you're talking about with out there on the New England area. But
Yeah.
um, there's stuff here that gets wild too. Like they come out with these like bundle care initiative programs or bundle programs, and looking at it from the top layer, you're like, yeah, we'll do a total knee for $20,000 or whatever, or 21,000. And then by the time it's all said and done, they're like, well, no, we're going to add therapy in now. Now we're going to add labs in. Now we're going to add this in. Now we're going to add that in. I'm like, whoa, wait a second. The contract doesn't say that.
Yeah.
Well, we feel like that's still part of the day of service because you're prescribing it on day of service. And I'm like, no, that's not how that works. So, there's been some, I wouldn't call them like fishy or anything, but there's been some kind of exploits that have happened where, you look at it and you're like, okay, this just doesn't make any sense. So I don't know. I don't know how those docs survive other than, you get to a place where it's like a coalition of docs, like a big private group, big
Yeah.
multi-specialty group, and you find safe haven in that, right? You say, okay, if we could, you're in the New Jersey area or whatever up in the Northeast, like join another private group that's similar to you, thinks the same way, and kind of see if that works. Like at some point in time, I do think, and maybe this is just like a fool's errand on my part. I think eventually that pendulum will start to swing back. I
Okay.
think it has to, right? Because physicians are of the accord where they're scientists, but they're still independent thinkers most of the time. Like
Sure.
they don't necessarily want to follow the herd.
Sure.
So eventually, 20 years ago, the pendulum was way over here and it said, okay, 25% of doctors are employed. We're way over here now where 75% of them are employed. I think it's gonna swing back towards the middle where it lands in a 50-50 here in the next 10, 15 years, potentially.
I sure
I
hope
mean,
so because you do not want that to go any closer to 100%. Patients need
no,
competition for their care to be top notch, bottom line.
yeah, yeah, I think that's right. Like you can't say everybody works for one person and expect there to be delineation or differentiation in the care model
Yep.
because they're all going to be bound to one thing, and it's the contract that they have with their employer.
Yep.
So, we're running into that today. We're recruiting doctors, like our last two recruits we were offering contracts to, both of them have been employed by hospitals before. And they're like, I can't do this. I cannot do this. Like, I have to be independent. Like the one we just hired was employed by a big academic hospital. And he's like, oh my God, I have freedom. Like I can breathe. Like, and then the next two we're looking at, one was employed by a big hospital system, just got bought out. The other one went to go work for a group that sold to private equity, and then the private equity group flipped him to the hospital.
Yeah.
And he's like, I got bought and sold twice before I even started my job. I'm like, holy crap.
What a roller coaster. And he hasn't even
Yeah, yeah. So
been.
he worked 6 years, there for kind of for the hospital. And he's like, it was great. I got a good experience. It was awesome, but I figured out what I don't want to do.
Sure.
So I think you're gonna find where like the value of lifestyle, flexibility, freedom, autonomy, it's going to draw some of these docs back out. And, I think a lot of it is geared towards the fact that like the residency fellowship, the education programs that exist today for doctors, and the same thing for like health administration when I went through, they're all geared towards pushing people to a big hospital type system
Sure.
because that's just all they know. They don't
That's
know any they don't know any different.
You're going to a
And
university to learn how to run a medical group, and they're going to
yeah,
teach you how to bring them to the hospital.
100%, right? So like they don't know any different. What are the expectations, right? So like if you don't know something, what do people instantly do? Oh, that's scary. I don't
Yep.
know that.
Yep.
Like so it's like I don't want to say it's like fear mongering, but there's like this predisposition when these docs come out. They're like, "Ooh, private practice is dangerous because all you guys care about is money." Well, quite honestly, no. Like, if we cared about money, we'd cut everybody's back open who walked in this joint. Like,
Yeah.
that doesn't happen at all. Like we just crossed the line of 100,000 encounters this year.
Wow.
Uh,
It's huge.
well, in a rolling 12 months. And,
Amazing.
we operated on less than like 9,000 people. So,
It's amazing.
that's a 9% conversion rate. Like,
And I'm sure your
yeah.
docs are happy to keep that below 10%. That's the goal, right?
They only want to talk about surgery when it's necessary. I
Sure.
mean, like they're not in a position where they want to operate on people unnecessarily because then you start getting to the bad outcome arena.
Yeah,
And
of
we just
course.
can't stand for that. Like our reputation is too meaningful for us. It
Yep.
takes, one of our docs said it takes a lifetime to build a reputation and you can crash it overnight.
Of
Like
course.
we're not going to be in that position where we're crashing, 50 plus years of history, tireless effort into this thing to just throw it all away. Like this
Yeah.
is a long haul operation.
It's a pretty simple rule of thumb, but I think you got to live by it if you're a successful group. It's only do what you would do to your loved one, do to your mother, do to your brother, do to your sister. Bottom line.
Yeah. We've got, it's like fundamentally just a simple thing. Like you said, it's one rule, right? Just always do the right thing.
Yeah.
Always do the right thing. Like we're always going to be in a defensible position if we're doing the right thing for our patients and for our employees.
Sure. So I heard
So,
a stat that over 20% of the entire GDP is spent on healthcare. If
yeah.
if this is in fact true, that's wild. Where is that
Yeah.
money going, and how could this be something that we start bringing down?
Yeah. Well, it's not, I'm not getting any of it. We're not getting any of it, the 20%. I think the funny thing is like you look at like the statistics that have come out like post COVID on the amount of healthcare spend or healthcare percentage of the GDP that exists today. You just got to follow the money, right? Like, if you start searching the stock exchange and you find that United Healthcare is one of the top 5 market cap companies in the world, where do you think the money's going? Like 20% of that is spent on healthcare. 9% of the GDP is spent through Optum, United Healthcare, SCA. So 11% is left over for everybody else in that healthcare arena. Like
Got
think
it.
about that. Think about
Wow.
that for a second, right? Like
They're taking
so
their you know
uh,
45% rip of the pie right off the bat.
yeah, yeah. So like it all comes down to the premium dollar, right? Like we're all chasing the same thing. And I heard somebody say, well, all these health insurance companies operate like at a 4% margin or something like that. And I'm like, I don't know how that's even true. They're to the point now where the insurance companies aren't just insurance companies
Right.
anymore. They're
Right.
they're a bank. Like they are a bank. They're investing in things. They're buying corporations. They're buying technology platforms to steer more patients to themselves. They have all of their own private funds like that are, kind of unknown that they're investing through, like Blue Venture Capital Fund. That's a Blue Cross Blue Shield fund that they're investing into. They're investing
Sure.
into health tech companies to say, Elliot, we don't want you to go see a doctor. We we want you to see one of our health coaches, and then these are the people we're going to steer you to. Well, who
Sure.
the hell do those people work for? They work for them.
Yeah.
So, it's like there's this whole philosophy of like, if you get a patient in your practice, from the scarcity mentality, you just want to close the lid on the screen as quick as possible so they never leave. And that's what a lot of groups do, is the lifetime value of a patient is very, very, it's extreme. Like, and you want to do as much as you can to widen that funnel to get more people through your door. And
Sure.
that's our same strategy, right? Like, there's no, like, I'm not calling anybody out. We're doing the same thing. So, our philosophy is just get them in as fast as possible and take good care of them.
Sure.
And I think when you look at the overall portion of the healthcare dollar that physicians made up as a percentage of the GDP, that's where life gets interesting, right? Like, how much of that GDP actually went back to physician reimbursement? Let's say 20%, okay, 9% of it went to Optum. So there's 11% left over. I want to know how much of that 11% went back to the doctors. I don't know. I don't know how much that is, honestly, but that's the fascinating number to me. Because, like, the only people in this country that can deliver healthcare are providers.
Sure.
That's nurse practitioners, PAs, doctors, nurses in some states, chiropractors, all sorts of different providers, like
Sure.
the all-encompassing term.
Sure.
And if we're saying 9% of that went to an insurance company,
It's wild.
that's
Something's
kind of a
off.
problem. Something's off. The math doesn't kind of add up. Something smells weird, right? Like,
Yeah.
we've got to kind of suss this out. So, like, I think there's got to be like some kind of um, potential healthcare law reform. But the question there, like, you beg to ask, like, okay, well, why the hell hasn't that happened yet? Well, who pays for most of the lobbying in our
Yeah.
country?
Who runs
Like,
DC?
yeah, yeah. Like, who's lobbying these guys and taking them out to a nice steak dinner or whatever? Like, we don't have a lobbying power like they do. So, and then on top of that, you think about like all of the companies that are out there that have exploited the dollar out of the American public. The PBMs, they've done a terrible job of cost containment.
Yeah.
You also look at like the drug manufacturers.
Oh, yeah.
They've just nickeled and dimed everybody to death.
Sure.
Um, like when the EpiPen sold, they quadrupled the price or something like that the minute they bought the EpiPen.
Yeah. It's horrible.
You look at like AbbVie with Humira, that was a $200 billion drug or something at one point. Like, and patent came off finally, and now all these biosimilars are going to pop up. And they just pushed all their marketing dollars into the next, hot fad drug they have. So, like, I don't have an answer for it other than me just complaining all the time. But um, if enough people are educated and informed and give a shit, you'd love to see some change happen.
Yeah. And it seems like the only way to really do it is from the ground up. You're not doing it from the top down. And I think, getting these physician led coalitions in every state to all come together and try to, build strength with numbers might be a potential starting point. And that's a goal of our podcast, is to keep opening up these conversations and hear what's happening in different parts of the country. And, maybe once we're done with 250 podcasts, we'll bring all of our guests together to have a meeting of the minds once we have enough equity between all the different groups that we're chatting with. But it's something that it has to change, or the next few generations might be dealing with really horrific healthcare environments.
Yeah, I mean, that's the worry, right? Is like, we've already made a mess of it, but what does it look like for the next iteration or next wave, the next generation? Like my kids, right? Like,
Yeah.
what is their healthcare system going to look like?
Sure.
And I don't know that any of us have been fiscally or socially responsible enough to actually tune into this in a way that's been meaningful, because we've been so worried on everything else, like inflation and our 401ks and this and this and this. This isn't like an issue that happened overnight, right? Like, it's happened for years,
Yeah.
and it's kind of just been left unchecked for so long that now all of a sudden it's a big problem. Kind of goes back to that frog and boiling water analogy, right? Like now we're all sitting in the water and it's starting to get real hot. And we're
Yeah.
like, okay, we should have jumped out like a while ago. But um, for me, I'm like a habitual problem solver though. Like I look at this and I go, okay, let's do it. Let's figure it out because like, why not? What better thing to spend your time on than trying to solve a crisis like this that actually is going to deliver some value to people?
Sure.
Uh,
Sure.
I think that's where our group comes in at, right? Like as a private orthopedic group, we're looking at it and we're going, hell yeah, let's do it. Like let's solve this. Okay, Elliot, you got an issue? Let us take care of you. We're pretty damn good at taking care of you. Come see us. So, I think that's where the groups that are up for task, really want to tackle the problem. They're
They're
going to figure
getting,
it out.
they're excited to tackle this extremely complex puzzle.
100%. Yeah. And I'm sure like of the other people you talk to that are similar minded in our space, they say the same things.
Yeah. Yeah, I've had a lot of similar conversations with other CEOs and executive level individuals that are running large groups like yours, and everyone knows uh, the pain points, but then it's so hard to back into, well, how do you change it?
Yep. Yeah. That's that's the true like where the rubber meets the road, right? It's
Yeah.
like, okay, the sick care system of our country is broken.
Hmm.
How how do we, categorically address it?
Yep.
And, for us, we look at it and we go, okay, the easiest way to try to make private practice financially solvent in our market is everyone coming together.
Yep.
Everyone come together. Let's pool our resources, like you pay for this, we pay for this, we pay for this, we pay for that, we pay for that. Like we don't have to be paying for all these little bitty things. Like
Sure.
let's all pool it and say, okay, we're gonna have one HR system instead of nine for
Yep.
all of our groups. And let's pool that together. We don't have to pay our admin fees to nine different 401k brokers. We could pick one 401k administrator.
Yep.
Like
Yep.
it's all these different things. But I think the one of the biggest barriers I've found in like trying to have those conversations is like there's an infinite amount of trust issues that exist. And it should be like you wouldn't think it would be that bad since it's like different specialties and all this different stuff. But like the physician to physician trust is very, very low for some reason. Like you'll
Yeah.
refer a colleague to them, or refer a patient to a
Sure.
colleague of yours. But like kind of the getting in bed with them and saying, hey, we're all going to come together under one big tax ID and
Yeah.
grow a group together. That's when everyone's like, whoa, hold on a second. I'm happy to refer to you and work
Sure.
with you. And I'm going to complain about my situation, but I don't really want to address it in a way where like, we're kind of holding hands now all of a sudden.
I think
And I
you're
think,
100% right. That's a great starting point, which is having providers put their guard down, put their egos aside, and be much more open and willing to join other groups that can complement your population and communities you serve.
yeah, that's what it has to be. And like, if we're walking in the door trying to have one of those conversations and it's instant, just like, I'm going to have my deflectors up and I'm not going to be an active participant in this.
It's not going anywhere.
It's no, it's a non-starter, right? It's not
Yeah.
going to go anywhere. The
Yeah.
groups are just going to go, well, it's good to see you. We'll see you later.
Yep.
How's that referral I sent you? It doesn't, it's non-productive.
You honestly
So
need
like,
a very talented, neutral, non provider like yourself to paint the picture for these groups on all the upside with joining forces and, being able to navigate who's going to mesh well together.
I would love to say that's right, but like you can't be a prophet in your own land. It's just it like
Yeah.
you you can't be like going out there preaching all of this and everybody just trusting you because
Yeah.
it doesn't work, unfortunately, because it's like, well, you work for that one group. Well, yeah, duh. Like I have to work for a group,
Yeah.
but like we could all work together. Like
Sure.
we're not gonna go sing kumbaya around the campfire, but like we can all come together and say, you know what, this is better for all of us.
And
Like
here's why.
it's 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 sure as heck better than becoming unemployed, in 3 years, or becoming employed by somebody else. Like let's figure this out to where we all kind of have a future ahead of us.
Or getting burnt out earlier than you need to be, if ever at all.
Yeah, 100%. You see a lot of docs today, the age of retirement amongst physicians, um, that used to be a lot older.
Yeah,
And
sure.
now post COVID, you're seeing that number just trickle down a little bit, where docs are
Yeah,
like, okay, 62, I'm out. I'm going to go get a locums job or be part-time or go do something else. I don't have to do this anymore. And it's like,
yeah. Scary. Specialists
okay,
are drying up.
yeah, 100%. And I like, there's got to be, we've got to address it on a multitude of levels, right? I think your thought process on start from the bottom, work our way up as opposed to the top down, because we're just not going to see it. We're not going to see anything get addressed from Washington or law policy or anything like that, just because it's just not going to happen.
Sure.
I'm probably sound like a pessimist, but it's just not going to happen there. If it was going to happen, they would have done something.
Yeah.
Uh, so I think you're going to see where it's going to be like the grassroots movement type of mentality, where it's like, okay, Elliot, you and I, let's do it. Let's figure it out. Let's band together. This sounds like a great idea. I'm all in.
Yep.
And then it just starts with transparency. You got to be like,
Trust.
okay,
Trust.
here's the trust and transparency to actually share information and data, and be willing to be an active participant and get somewhere. Because ultimately, like you said at the very beginning, like the patient's the one who's paying the cost. The patient's the one who's held hostage, when it all comes down to it. Like if we're not aiming to deliver a better value proposition to the patient by doing something like this, we shouldn't do it. We shouldn't aim
Sure.
for that.
I couldn't agree more. At the end of the day, the patients will suffer, and I feel truly that we could be entering a pendulum swing, as you referred to it, where the providers realize they're never going to be able to tackle this beast alone and have to start, you know, becoming partners with their competitors.
Yeah, and I think that's like a common um, misconception is competition, right?
Yeah,
Groups that are similar to us, if they think like we're competitors, and it's going to hurt if we come together, that's just not even true.
not even
Because
close.
like the biggest competition, one of our docs said it in a meeting. He goes, the biggest competition to me is the other guy sitting right there who does the same thing I do in my own practice. Like
Sure.
it's not you outside my four walls.
Yeah.
It's my own partners. Like, because he does the same thing I do. Who does
Yeah.
it better? Well, we don't know. We got the outcomes to show who does it better, but like, that's my competition.
Yeah.
And like,
A healthy competition.
it's a healthy competition because we're the rising tide raises all ships, right? So
Of
like
course.
if he makes more money, then that helps our overall practice. That helps the engine, right? It just
Yep.
keeps
Yep.
feeding the machine. So like I think that's where things get really like I think really misunderstood.
Sure.
Is like people look at it and go, okay, well, we're competition. Well, no, we're not.
Yeah.
We're not competition.
There's
We're
plenty of
coexisting.
patients who need help.
100%. Like if we think that we're going to have 100 orthopedic providers drop in our lap tomorrow, like that's just not going to happen. The,
Sure.
the competition has existed for ages. I mean, like that's not going to go away. And like patients self-select based on multiple factors to see who they're going to see.
Yeah.
They're not picking you off of just nothing. Like
Yeah.
patients are picking you off of several different things today.
Sure.
Like your digital presence online, that means something to patients. Like some of our docs are like, that's stupid. I shouldn't have to have some kind of Google page. I'm like, well, you have to. You
Sure.
have to get
As
over
a
it.
medical marketing agency, I hear that all day.
Yeah, it's like I don't need to be active on my Facebook. I don't even have one of those. Okay, well, you don't have to be on your own individual page, doc, but like our group has to be active, posting
Sure.
something, not
Sure.
not looking like we have no presence, that we don't exist. Like, I gave a talk at a conference a couple of years ago. It's like 4 out of 5 patients look online.
Yeah, they want to
You know,
watch videos and read reviews.
yeah,
They're gonna do their research, no doubt.
100%. And like I think 20 years ago, before like all the crazy internet of things we have today,
Yeah.
like you didn't have to do that. You're
Yeah.
right. You know why? Because the internet didn't exist. Like
Yep.
the world's different today. Everyone's walking around with a freaking computer in their pocket.
Yep.
Like you got to do
Adapt with the
something.
times or get left in the dust.
100%. Yeah, absolutely.
Andrew, let's leave this conversation. It's been a fabulous conversation, and I know we've covered a lot, and our audience will have some great takeaways here. Let's leave on a high note. Tell me about the 5-year plan for Columbia Orthopaedic Group. What are you excited about for the future?
Yeah, so that's a good question. So we we don't work off 5-year plans anymore.
Okay.
We
What about the
we work
3-year?
Yeah, we work off of a much shorter plan. So we're a 1 to 3 year organization now because the
Sure.
world changes. Like
Sure.
like the world changes
Fair.
so quickly. So our 1 to 3 year, and then if you want to say long range, 5, 10 plus year plan, we would look at it and say, we're a big operation, right? Where we're at 92,000 square feet institute, 80 plus exam rooms, 30,000 plus square foot surgery center. Like
Wow.
we're the Mecca. We're the Mecca where we are. We do a really, really good job when it comes to patient care. We put a ton of resources in. I was kind of jokingly saying those groups that are going to try to find a competitive advantage, they're going to add things, right? Well, we've been adding things for years. We've got a patient engagement solution that's completely tech driven. So patients can enroll in our solution and get virtual physical therapy. They get a nurse navigator, a real person, not an AI or a chatbot, a real person
Sure.
that is assigned to them to chat with whenever
That's
they
awesome.
want, whenever they have questions. We
Sure.
just put in a lab here on site. So all of our
Yep.
patients go to the labs drawn. We've got a retail pharmacy, DME, an MRI center, surgery center. We've got everything in house that a patient would possibly need.
Sure.
So for us, what we look to aim at over the next 1 to 3 years is, we've got a lot of resources here. Like we're a very, very well-run machine, but there's a lot of groups that aren't, and there's a lot of groups that need help. So our model is going to be, how do we help? What do we do to help you sustain? Is that where, you come join us? Is that where we join, we create a new company together, we all join it? So there's a lot of different models out there.
Yep.
Our strategy is very much focused on the community that we serve wherever we're at.
Sure.
So we do a lot of not-for-profit partnerships. We partner with the school systems on sports medicine or athletic coverage.
Sure.
Not going to stop,
Yep.
so we're expanding our geographic footprint pretty rapidly. We just opened a brand new clinic in July. We're going to be opening 2 more clinics within probably inside of 6 months to a year on top of that. So we're going to go from 1 location to 4 inside of a year period.
Wow. Big jump.
It's a big jump. It's a bold jump, right? But we think that, from a market capitalization standpoint, like you've got to expand to offer people something more.
Yeah.
Like people expect more, and you got to position yourself to deliver that. So if we're not going to do it, somebody else is going to,
Sure.
and we don't want to get left behind. So for us, the way we kind of imagine our future is it's going to be very heavily invested in partnership and collaboration, both with
Sure.
community and other private docs.
Yep.
It's going to include a lot of geographic expansion for us. We've got really, really bold plans inside of the kind of the Missouri market for orthopedics. We have a lot of kind of high level things that we're trying to work on that will continue to increase value for patients coming to see us and our peers just like us.
That's amazing. It sounds like you have a lot of growth ahead of you in the near future, and you have an infrastructure and a well-oiled machine to confidently pour gas on, right? So I congratulate you to building that environment where you're ready to scale, and you know other groups that partner with you and merge with you are only going to succeed.
100%. Like that's the only, like you said, the well-oiled machine with the gas, right? Like we're just loading it up. Just keep loading the machine. Like I said, we crossed the threshold of 100,000 visits in a rolling 12-month period. First time we've ever done it.
Wow.
And that's a big feat for us. And like it wasn't like the first time we've ever done it. I mean, we blew it out. We went up to like 103,000. The closest we'd ever got before was like 98,000. So
Wow.
we're really like fueling the growth by trying to bring in high level providers. We're changing our service offerings quite a bit. And that's like that aircraft carrier, like we talked about at the beginning. Like we're such a big group, but like we're still nimble enough where we can pivot. We can
Sure.
quickly pivot. Say, we're going to head this direction, or we're going to try this, or we're going to do that. And from a support standpoint, like we've got 26 private physicians that are invested in this. They are the private equity. Like they're the ones who want
Sure.
to see this succeed. And they're also still willing to kind of stick their neck out and say, you know what, let's head in this direction and see what happens, because this sounds like a good plan. This sounds like the future. It sounds like a way to help others, help ourselves, help our patients. Like, let's do that. That's cool. That's great. That's mission driven. That's
Sure.
how we can do things to help people. So
I love
that's
it.
our plan.
I love it. And thank you for sharing that. It sounds like you joined a really good team and you're leading a really, really good team. And you guys are trailblazers and delivering premium patient care. And I'm excited for you guys. So thank you for sharing all of that.
Yeah, thanks, Elliot. And when you get up to that 250 people and you're ready to have the meeting to talk about how we solve this healthcare thing, I'm ready.
Awesome. I will definitely stay in touch. And maybe we'll do a second episode with you in a few months down the line, sometime next year, to hear what's happening with Columbia Orthopaedic.
Yeah, that sounds great. Thanks so much for having me. I appreciate it.
Oh, the pleasure was all ours. Thanks again, Andrew.